Hello everyone. Today we are going to discuss the topic immunosuppressants. We are going to discuss this topic under the following headings. We shall be looking into the classification of immunosuppressants, and we shall be broadly looking into two of the major classes of immunosuppressants, that is calcineurin inhibitors and mTOR inhibitors. There are other classes of immunosuppressants like the anti-proliferative drugs, corticosteroids, and biological agents. But since you have studied these drugs in the previous topics, I'm not covering this again here during this session. Finally, we shall also be looking into the different immunosuppression regimens which are used in organ transplantation. Before we go into the immunosuppressants, let us have a recap of the immune mechanisms, which you have already learned in phase 1. But there are two types of immune responses. One is the humoral immune response, and the other one is the cell-mediated immune response. So during the humoral immune response, the antigen, which is processed by the macrophage or the antigen presenting cells, is coupled with the major histocompatibility complex class 2 and is presented, and this is presented to the CD4 helper T cells with the help of the MHC class 2. So you can consider this MHC class 2 as a plate on which this antigen is presented to the CD4 helper T cells. The CD4 helper T cell is kept activated by the interleukin 1. Now, when the antigen is presented to the CD4 helper T cell, which is activated by the interleukin 1, it starts proliferation and starts secreting cytokines. These cytokines cause the proliferation and differentiation of antigen-activated B cells into plasma cells. Now, these plasma cells start secreting antibodies which bind to the antigens and inactivate them. This is about the humoral immune response. Now, in the cell-mediated immunity, the antigen is processed and presented to the CD4 helper T cells, which starts producing the interleukin 2 and other cytokines. And these interleukin 2 and other cytokines, will in turn stimulate the proliferation and maturation of the precursor cytotoxic lymphocytes or the killer T cells, which have been activated by the antigen presented with the help of class 1 MHC. So here the antigen is presented with the help of class 1 MHC. In the humoral immune response, it was presented by class 2 MHC. Okay, now then the mature killer cells recognize the cells carrying the antigen and they lyse them. This is about the cell-mediated immune response. Now, let us see what are immunosuppressants. So, these are the drugs which inhibit the immune responses. They can either inhibit the cellular or the humoral or both. So, where are these immunosuppressants used? So, they are used for preventing graft rejection during different types of organ transplantation, like the kidney transplantation, bone marrow transplantation, and so on. They are also used as second-line drugs in autoimmune diseases like rheumatoid arthritis, severe psoriasis, myasthenia gravis, and it is also used for Rh hemolytic diseases. Now, let us look at the classification. The classification includes calcineurin inhibitors, examples, Cyclosporin and Tacrolimus. Then we have got the mTOR inhibitors, which include sirolimus and everolimus. Then comes the anti-proliferative drugs, which includes azathioprine, methotrexate, cyclophosphamide, mycophenolate mofetil, glucocorticoids like prednisolone, and biological agents like TNF-alpha inhibitors, interleukin-1 receptor antagonist, interleukin-2 receptor antagonist, anti-CD25 antibody, and polyclonal antibodies like antithymocyte antibody. So the last three classes of drugs have been covered in the previous topics. So I'm going to discuss about the first two classes, that is calcineurin inhibitors and mTOR inhibitors. But before we go into the important classes for today's session, we can just have a broad look at the basic mechanism of action of all the classes of drugs. So the glucocorticoids, they will inhibit the MHC expression and the production of the interleukin 1, interleukin 2, and interleukin 6, so that the helper T cells are not activated. So as I told you in the previous slide, the activation of the helper T cells requires the presentation of the antigen with the help of MHC. Now, this step itself is being inhibited by the corticosteroids. So, the initial steps itself is inhibited by the glucocorticoids or the corticosteroids. Then comes the anti-proliferative drugs, which are involved in the inhibition of the proliferation and differentiation of both the T cells as well as the B cells. Then the classes for today, that is the the calcineurin inhibitors and the mTOR inhibitors, they inhibit the antigen stimulated activation and proliferation of helper T cells, as well as the expression of interleukin and other cytokines from them. But this is the area that we are going to concentrate today. So once again, I'll tell the mechanism of action in brief. That is, the cyclosporin, tacrolimus, sirolimus, etc., they inhibit the antigen stimulated activation and proliferation of helper T cells, as well as the expression of interleukin 2 and cytokines by them. Okay, so with that, I think we'll proceed on to the first uh, class, that is calcineurin inhibitors. So the first example is cyclosporin, and it is a cyclic polypeptide which is obtained from a fungus, and it is a highly selective immunosuppressant. So as I've just told you what the mechanism of action, it is preventing the antigen stimulated activation and proliferation of helper T cells, as well as the expression of interleukin 2 and cytokines by them is also inhibited by cyclosporin. Now let us understand this in a little greater detail. So this is a structure you can see here. Now, this is the antigen presenting cell. One of the examples of an antigen presenting cell is a macrophage. And here, this is the MHC class 2, and here is the antigen. Now, this is the T cell, and this is the T cell receptor, and nearby that you have the CD4 molecule. Okay, now what happens during the activation of the CD4 T cell? That is what we are going to see first. The first step that we are going to see is the how the CD4 T cell gets activated on when it is presented with the antigen. So as I've already told you, the structure of the helper T cell, it has got a T cell receptor, and very near to it, there is a CD4 molecule. Now, if you look at the MHC and the antigen, it is like a lock and key system. You can see that the antigen can just fit into this T cell receptor, and the CD4 has a configuration which is like a lock and key system with the MHC class 2. So this once the so the T cell receptor anchors the MHC class 2 with the antigen on it. Okay, that's the first step that is happening. Now, this stimulates once this anchoring occurs, it will stimulate the T cell, and this will cause the phosphorylation of the phospholipase C. This is the phospholipase C, cause the phosphorylation of phospholipase C, and this will cause the hydrolysis of the PIP2. Here it is a PIP2 into IP3 and DAG. Now IP3 will cause, here you can see the IP3 will cause the release of the intracellular calcium, and this calcium will bind to the calmodulin, and it will activate serine threonine phosphatase, which is called as calcineurin. This is the calcineurin. And now this calcineurin will dephosphorylate a regulatory protein called as NF80. This is the NF80. The full form of NF80 is nuclear factor of activated T cell. Okay, now when this NF80 is activated, this leads to the transcription of cytokine genes and interleukin 2, then the other cytokines will be produced. Cytokines, you can see the cytokines being produced. This is a structure, this is the complete pathway of activation of CD4 helper T cells when the antigen is getting bound to it. Now, what happens when cyclosporin is given? Okay, so cyclosporin, you can see here, it is entering into the target cell. It is binding to the cyclophilin. This is the cyclophilin, which is a kind of immunophilin. Now, the cyclosporin cyclophilin complex, it will just go and inhibit the calcineurin. So once the calcineurin is inhibited, what will happen? There won't be any activation of NF80. And when there is no activation of NF80, there won't be any transcription of cytokine genes. And there won't be any production of cytokines like interleukin 2, TNF alpha, etc. So when you are going to describe the mechanism of action of cyclosporin, it is preferable that you first tell the normal activation of the CD4 helper T cell, and then you tell how the cyclosporin is inhibiting this process. Okay, now let us look at the pharmacokinetics of cyclosporin. So it is metabolized by CYP3A4 enzyme. And whenever a particular drug is inhibited by CYP3A4, you should consider the possibility of drug interactions, that is, especially by the enzyme inhibitors and inducers. This is a drug which is exuded in bile, and the specific characteristic of cyclosporin is that it has got a biphasic T half. So you can see that it has got a T half that is 4 to 6 hours and the elimination T half of 12 to 18 hours. So one drug which has got a biphasic T half. Now let us look at the adverse effects. So you can see here, hypertension, diabetes, hirsutism, hyperplasia of gums, anorexia, hyperkalemia, hyperuricemia, tremor, seizure, nephrotoxic, and hepatotoxic. So many of these areas, especially hypertension, diabetes, hirsutism, hyperplasia of gums, all these are very similar to the ADR of phenytoin. So if you are ever asked about two drugs which cause hyperplasia of gum or gum hypertrophy, you can always mention cyclosporin and phenytoin. Then, being a drug which suppresses the immunity, the chances of opportunistic infections is very high when you're using any immunosuppressant drug. Then comes the drug interactions. So this is a drug. Cyclosporin is a nephrotoxic drug. I've already shown you as the ADR. One of the limiting toxicities of cyclosporin is nephrotoxicity. So always remember that. And so if you're giving cyclosporin with other nephrotoxic drugs like aminoglycosides, vancomycin, amphotericin B, NSAIDs and all, it will enhance its toxicity. So patient will have a double attack of kidney damage if you're giving all the nephrotoxic drugs together. Then comes the enzyme inducers like phenytoin, phenobarbital. If you're giving these enzyme inducers along with cyclosporin, then it will lower the, it will cause the metabolism of the cyclosporin, lowering its blood level, and that can lead to transplant rejection reaction. Remember, this is a drug which we are using to prevent the rejection. Now, if the blood levels are not adequate because of some drug interaction with an enzyme inducer, then the transplant rejection will happen because the drug will not be able to stop the transplant rejection with the available concentration in the plasma. The contrary to that, if you're giving CYP3A4 inhibitors, that will inhibit its metabolism and increase its bioavailability and can also lead to its toxicity. Then marked hyperkalemia can occur if you are giving potassium supplements and potassium sparing diuretics along with cyclosporin. Now, where are we using this? So it is mainly used for prevention as well as treatment of graft rejection reaction. So when we discuss about the immunosuppression regimens, you will understand this better. That is, we are trying to prevent the rejection. For that, we are using this. And also, if there is a rejection already occurring, to treat that also, we can use cyclosporin. And it is used in all kinds of transplantations like renal, hepatic, cardiac, bone marrow, and other transplantation. So one thing that has to be taken into consideration is that it has got some nephrotoxicity, and the major limiting toxicity of cyclosporin is nephrotoxicity. So we have to be very careful when we are using it in renal transplant. It is also a second-line drug in autoimmune diseases like rheumatoid arthritis, inflammatory bowel disease, psoriasis, etc. And it is also used for aplastic anemia. Now, one of the advantages over other immunosuppressants is that it is only suppressing the cell-mediated immunity, and it is not suppressing the humoral immunity. So this is a very big advantage, because during it will help in the, while it is helping in the prevention of graft rejection, there is enough immunity left in the body which is there to combat any kind of bacterial infection. Otherwise, if it was if it were to suppress both the cell mediated and the humoral immunity, then the person will be subjected to many opportunistic infection. But the advantage of this drug is that it is only suppressing the CMI and not the humoral immunity. So there is adequate immunity left in the body to combat bacterial infection. And it also doesn't cause any kind of toxic effects on the bone marrow or the RE system. Now, the next drug under calcineurin inhibitor is tacrolimus. This drug also has got the same mechanism of action as that of cyclosporin. That is, the only difference that is there with the mechanism of action is that it is binding to another immunophilin. The cyclosporin was binding to immunophilin called as cyclophilin, and that is a complex which was going and inhibiting the calcineurin. Here, the immunophilin, the name of the immunophilin to which the tacrolimus binds is called as the FKBP, that is FK binding protein. And this is the only difference in the mechanism of action. And this, the tacrolimus and the FKBP complex goes and inhibits the calcineurin, and the rest of the steps are very similar to that of the cyclosporin. The pharmacokinetic, it is administered both orally and by IV infusion, and it is also available for topical use. The absorption is decreased by food. This is also metabolized by CYP3A4, and it is excreted in bile and has a T-half of 12 hours. So unlike the cyclosporin, it is not having a biphasic T-half. So when we compare the adverse effects, you can see that it is the ADRs are quite similar to that of cyclosporin. Only there is a difference in the like the proportion. You can say that the adverse effects like neurotoxicity, the propensity to cause diabetes, alopecia, diarrhea, nephrotoxicity is more than cyclosporin, whereas it is having the risk of hypertension, hyperuricemia, hirsutism, and gum hyperplasia is comparatively less than cyclosporin. But all these ADRs are present in tacrolimus as well. But when you compare with cyclosporin, the incidence may be comparatively less or more. Now, the uses are that it is used in all kinds of transplantation. And one of the advantages over cyclosporin is that it can be used in rejection reaction, which is not suppressed even by cyclosporin. It finds its use in liver transplantation and also in fistulating Crohn's disease, and in atopic dermatitis, it is used in the topical dosage form. Now, when we compare cyclosporin and tacrolimus, tacrolimus is 100 times more potent than cyclosporin. And as I already told you, it is by the immunophilin to which both these drugs are binding is different. Cyclophilin is the immunophilin to which cyclosporin binds, and FKBP is the immunophilin to which the tacrolimus is binding. Now, the absorption of cyclosporin is dependent on bile, whereas it's not dependent on bile in the case of tacrolimus. And now the cyclosporin is mainly for the prevention of rejection reaction. It can be also used for treatment, but it is mainly for the prevention. But tacrolimus is also used for the treatment of acute rejection. Cyclosporin has got a biphasic T-half. The other one doesn't have a biphasic T-half. The routes of administration of cyclosporin are only by oral and the IV route, and tacrolimus is given by oral, IV, and topical form is used for atopic dermatitis. Now, let us see the mTOR inhibitors. Under this, we have got two drugs, that is sirolimus and everolimus. The sirolimus was previously called as rapamycin, and it is a derivative of macrolide antibiotic. The mechanism of action is that it is also binding to the immunophilin, FKBP, just like tacrolimus. But the difference here is that sirolimus FKBP complex is not inhibiting the calcineurin. It is inhibiting another kinase, which is called as the mammalian target of rapamycin, mTOR. So instead of calcineurin, this is going and inhibiting the mTOR. Now, mTOR is a very important link in the pathway of the proliferation and differentiation of T cells. So you have to remember here that the calcineurin was involved in the activation of the T cells, whereas the mTOR pathway is mainly involved in the proliferation and differentiation of T cells. So now when the mTOR gets inhibited by the sirolimus FKBP complex, then the proliferation and differentiation of the T cells doesn't happen. So we can say that the sirolimus is arresting the immune response at a later stage than cyclosporin. So cyclosporin is at a very initial stage. It prevents the activation of the T cells itself, but this one is at a later stage. It is not inhibiting the activation, but it is inhibiting the further proliferation and differentiation of T cells. So in fact, this drug can be called as an anti-proliferative drug. Now, the pharmacokinetic is mainly given orally, and its absorption is reduced by fatty meal. It's also getting metabolized by CYP3A4 and is excreted mainly in the bile. T-half is around 60 hours. The uses involves, again, to prevent the graft rejection reaction, and it is an alternative to cyclosporin for transplant rejections in case of nephrotoxicity. So we already mentioned that nephrotoxicity is a limiting feature for cyclosporin use. So this is an alternative to cyclosporin for rejections which are in case of nephrotoxicity. It's also used for stem cell transplant. And one of the very important uses of sirolimus is it's used to coat the stents. Okay, and the coronary artery bypass surgeries, there is a stent that is put in the coronary artery, and to prevent its occlusion or the restenosis, to prevent the restenosis. So the stents which are put in the coronary artery is actually coated with sirolimus. This is one of the very important use of sirolimus that you should not forget. That is the coating of the stents put in the coronary artery to prevent the restenosis. Adverse effects, a notable adverse effect of sirolimus is bone marrow suppression, of which thrombocytopenia is most notable. Then hyperlipidemia, hepatotoxicity, hypertension, and GI dysfunction in the form of diarrhea. These are the adverse effects of sirolimus. When we compare with everolimus, the everolimus has got a better oral absorption. It has got a consistent bioavailability. The T-half is a little shorter. It's only 40 hours. And the everolimus has also got additional uses other than in the graft rejections and autoimmune disorders. It is also used in three important cancers, that is advanced renal cell carcinoma, breast cancer, pancreatic neuroendocrine tumor. So this is also having the additional use in malignancy. Now let us finally see the immunosuppression regimens that are used in organ transplantation. There are three types of regimens which are used, that is induction regimen, maintenance regimen, and rejection regimen. Now, this again can be a separate short note, and you have to write all the 3 regimens. So what happens in the induction regimen? Now, this is given in the peri-operative period. That is, it is started just before the transplant, and it is continued to 2 to 12 weeks after the transplant. And the common regimens which are used for induction include triple therapy, and we are using drugs which are acting at different steps of the immune response. So this, when you're using 3 drugs, we can use them at a comparatively a lower dose, and they can attack or inhibit different steps of the immune response. And at the same time, because we're using a lesser dose of each drug, the toxicity because of each drug can also be minimized. That is the rationale or the advantage of using triple therapy. So the triple therapy usually involves this regimen. That is one of the 3 drugs, that is cyclosporin or tacrolimus or sirolimus, plus a steroid, prednisolone, and an anti-proliferative drug like mycophenolate mofetil or azathioprine. So we already know that cyclosporin as well as tacrolimus are associated with a lot of nephrotoxicity. So the preferred regimen in people who could be susceptible to more nephrotoxicity is sirolimus, prednisolone, and MMF. Now, the maintenance regimen has to be given for prolonged periods. Maybe sometimes, in some cases, it has to be given lifelong. And again, we are using a 3-drug regimen consisting of maintenance doses. In induction regimen, we are using a higher dose, but in maintenance regimen, we are using a comparatively a lower dose of the following, that is cyclosporin or tacrolimus, sirolimus, prednisolone, azathioprine, or MMF. The 2-drug and 1-drug regimens are also tried, but they are associated with higher rates of acute rejections. Now, cyclosporin or tacrolimus regimens are associated with the risk of nephrotoxicity. So usually what is done is usually after 1 year of giving cyclosporin, it is stopped and other drugs are continued. But only risk that can happen with the stoppage of cyclosporin is the risk of acute rejection. So it had a decision of whether to continue cyclosporin or not has to be taken very tactfully, considering the risk and benefit ratio. In case of intolerance to the first-line drugs, like the above mentioned, second-line drugs like cyclophosphamide, chlorambucil, or tacrolimus are also substituted. The last one is anti-rejection regimen, and this is used to suppress an episode of acute rejection. The most common regimen is the steroid pulse therapy, where we are giving methylprednisolone 0.5 to 1 gram IV daily for 3 to 5 days. In situations where there is no response with the steroid pulse therapy, muromanab, CD3, or antithymocyte globulin can be used alone or combined with steroid. In cases where the steroid is not effective, or the patient is resistant to steroid and the rejections are not being controlled by the steroid alone, tacrolimus, sirolimus, or MMF can also be used. Now, in case the cyclosporin was not included in the maintenance regimen, even cyclosporin can be added to prevent an acute rejection. Now, the adverse effects which can be there for any immunosuppressant is the risk of opportunistic infection, that is risk of viral, fungal, bacterial infections, and also lymphomas, related malignancies can develop with the long-term use of immunosuppressants. So that's all for the class today. Thank you.